The VESALIUS trial. The effect of evolocumab in patients at high cardiovascular risk without a prior MI or stroke. Evolocumab has been shown to reduce the risk of cardiovascular events in patients with a prior major atherosclerotic cardiovascular disease event, such as MI or stroke. However, the clinical benefit of PCSK9 inhibition in patients without a prior MI or stroke is unknown. ASCVD can be thought of as a continuum of risk, ranging from patients with no known ASCVD who are at low risk with minimal risk factors, to patients with no known ASCVD and are considered high risk for development of disease in the face of risk factors such as diabetes or older age, to patients with evidence of atherosclerosis without a prior event such as MI or stroke, and then finally to patients with major ASCVD who suffered one or more major atherosclerotic cardiovascular events. Now, importantly, the prior cardiovascular outcome trials with PCSK9 inhibitors have focused solely on this highest risk group. The VESALIUS CV study included the populations in the middle, so patients with evidence of atherosclerosis without a prior event, and patients without known ASCVD who are at high risk by virtue of diabetes and other risk factors. The trial enrolled stable patients at high risk for cardiovascular events but no prior MI or stroke. 12,257 patients were included in the analysis and followed for a median of 4.6 years. Here are the inclusion criteria: coronary artery disease without a prior MI, cerebrovascular disease without a prior stroke, peripheral arterial disease, or high-risk diabetes. In addition, they had to have had at least one of the three lipid criteria shown here, which included an LDL of at least 2.3, one of the other lipid parameters, and also on background therapy of optimized lipid lowering. Patients were then randomized in a 1-to-1 fashion to placebo or evolocumab. Baseline characteristics were well balanced with no difference between the treatment groups. Median age was 66, 43% were female, 92% were white. In terms of qualifying disease categories, 2/3 of the patient met the criteria for at least one of the qualifying atherosclerotic disease states. Additionally, almost 50% of the patients had high-risk diabetes, and within this group, there was a third of the population who had high-risk diabetes without qualifying atherosclerosis. 92% of patients were on some form of lipid-lowering therapy at baseline, including 72% on high-intensity regimen, 68% on high-intensity statin, and 20% on ezetrol. The median baseline cholesterol was 2.82. In the CoreLab sub-study of approximately 2,000 patients, evolocumab reduced LDL to a median of 1.16, a 55% reduction, or an absolute reduction of 1.62. This was maintained over the course of the study. Here is the first of the dual primary endpoints, the 3-point composite MACE of coronary heart disease death, MI, or ischemic stroke. Evolocumab resulted in a 25% relative risk reduction with a p-value of 0.0001, highly significant. The second dual primary endpoint included ischemia-driven arterial revascularization, and there was a 19% relative risk reduction, again with a highly significant p-value of less than 0.0001. There are pre-specified secondary endpoints which are shown in the hierarchical testing order. The first of these key secondary endpoints were composites. As you can see, there was a significant reduction in all the composite endpoints here, including a 27% reduction in the endpoint of cardiovascular death, MI, or ischemic stroke. The remaining individual secondary endpoints are next. There was a 36% reduction in MI and a 26% reduction in ischemia-driven revascularization. The hazard ratio for coronary heart disease death was 0.89, which did not meet statistical significance, so because of the testing hierarchy, the remaining results should be considered exploratory. However, as you can see, there was a 20% lower rate of cardiovascular death and all-cause death. More specifically, you can see the rate of all-cause death in the placebo arm was 9.7, and the rate of all-cause death in the evolocumab arm was 7.9, for a hazard ratio of 0.8, with a nominal p-value of 0.0005. So in summary, in patients at high cardiovascular risk without a prior MI or stroke, the addition of PCSK9 inhibitor evolocumab to baseline lipid-lowering therapy resulted in a median achieved LDL of 1.16, a significant 25% reduction in the 3-point MACE composite, and a 19% reduction in the 4-point MACE composite, with consistency across subgroups, including those with diabetes and no qualifying atherosclerosis. Additionally, there was a 27% reduction in the composite CV death, MI, or ischemic stroke, and 36% reduction in MI, as well as nominally lower rates of cardiovascular and all-cause death. So in conclusion, the authors stated that the reduction in MACE seen in VESALIUS CV, which included patients with qualifying atherosclerosis as well as patients with diabetes without qualifying atherosclerosis, and achieved LDL of 1.16 in the evolocumab arm, supports intensive LDL lowering to this level even in patients without a prior major ASCVD event.